Delighted to have Dr. Fernando Torres joining us. Thank you, sir. We appreciate your time.
Thank you, Tom, for having me here. I love to talk about pulmonary hypertension and lung transplantation.
So let's get into that. In the work that you're doing now, it's built on the foundation of advancements over the past couple decades in PAH medications, but still patients worsen. What does modern medicine do today to try to alleviate that problem?
Tom, you have been talking about something that has been in the core of our foundation in pulmonary hypertension, trying to find a cure for this deadly disease. Over the past 20 years, we have done so many advances in the treatment of this disease, but still, our medications are not curing this disease. They are prolonging or expanding our life expectancy of our patients and providing them a better quality of life. Unfortunately, our patients are going to continue to deteriorate. And that's where I got interested in lung transplantation. We needed a safety net, something to protect our patients and give them another chance of life when our medications fail. So, during the past 20 years, we have been also, as we are working on helping our patients with medications for the treatment of pulmonary hypertension, we have been also developing technology and techniques to help the patients when that medication fails. So the first thing we did, we developed technology to help our patients transition into lung transplantation. If their organ was failing, how can we keep them alive until we are able to find a suitable donor to help them through lung transplantation and keep them alive until then? And that technology is called ECMO. Way back in the 1990s, early 2000s, the technology was so clumsy. We were not able to keep patients alive more than 1 week while we were waiting for a lung transplant. Currently, we can keep patients alive for 1 month, 2 months. That allows us to buy time to find that organ to then do a lung transplant. But not only have we been working on how to keep patients alive while we are waiting for lung transplantation, but also we have been working on how to get them a lung transplant and how to make that transplant successful.
Do you find it a last resort?
Absolutely. You never want to do a transplant if you have another option. Why? Because after lung transplantation, we have no other options. We have nothing else that we can offer that patient. So we are going to exhaust every medication, everything that we can, and try to use the native organs to keep that patient going. But if we are not able to, that's where lung transplantation comes into play.
So what are some of the considerations that you have when transplantation is on the table?
So the question is, when is it that is the right time to move towards transplantation? And believe me, it's a tough one, because we do not want to do a transplant too early, because after a transplant, our patients eventually will die. So you don't want to do a transplant too early, but at the same time, doing it too late, there are so many comorbidities going on with the body. The kidneys are not working as well, the liver is not working as well, the heart may not be working as well. So it makes the perioperative process of transplantation very challenging. So we need to find that sweet spot. And the main problem is we cannot time it. We cannot say, okay, in 2 weeks we will do this transplant, because we do not know if we're going to have that organ available in 2 weeks. So what we're doing is trying to use our best guess of when is it that is a good time. And we tend to use guidelines of survival for pulmonary hypertension. Are the patients able to walk far? How are the patients feeling, the functional class? Are they still on a functional class 4? Are they in a functional class 3? Are they moving towards a 2? stable functional class 3. So for the most part, if the patient is in a functional class 4, we'll move towards transplantation. That's an easy one. The harder one is when you are in a functional class 3, where patients are more or less stable, but you know that over the next 6 months, they are going to deteriorate. And you don't want to wait until they're so sick, where then doing a transplant is so risky. Obviously, if the patients have evidence of right heart failure with the kidney functions deteriorating, if they have biomarkers like the NT-proBNP that remains elevated, if you have evidence that the right ventricle is still very dilated. So we do monitor certain parameters to see if our medications are working or not, to make that critical decision. Let's move towards lung transplantation.
So you have guidelines to follow, but many unexpected variables.
Absolutely. There is no rule. This patient today should have a transplant. A lot of what we do has to be an art. Science helps us, but by no means is a check mark, this, that, etc., and you need to move to transplant, which makes it a challenge. But at the same time, it allows us to help patients that in the past would have died.
So you balance the science of medicine and the art of juggling, right?
Absolutely.
Very good. Thank you, Dr. Torres.
Thank you, Tom.